Good afternoon. It's a pleasure to welcome you to the NIH Director's Wednesday afternoon lecture, in particular this very special Robert N. Butler Memorial Lecture. Many of you will know that Bob Butler was the first director of NIA. Many of you will also know that he was an outstanding champion for the importance of research on older men and women, and had that understanding and insight far before his time. He has been recognized by many since, including, I should just comment, last week, AARP's designation of 10 all-time champions on aging, and he was one of those to add to his many honors. But when he came to NIA in 1976, it was an extraordinarily auspicious beginning. His reputation in the field, his advocacy for aging causes was well known. He came to NIA and then 2 days later was announced as the winner of a Pulitzer Prize in Literature for his insightful publication, Why Survive Being Old in America, which asked a question that was, at that time, a most critical one. It was very much relevant to the founding of NIA for that matter, but it was Bob's conviction that older people aged into a stage of life where they were of great value, where quality of life could be extraordinary. He was an outstanding and eloquent spokesperson for this, so that his vision for NIA, which survives, was one which emphasized the maximizing of quality independence of life. He recognized that potential, but he also recognized the threats that were posed by conditions that are associated with aging. And so he fought for a program of research that spanned basic biology, clinical geriatrics and gerontology, and the behavioral and social aspects of aging, which he felt to be equally important. There are many reasons to be proud of, for those of us who had an opportunity to interact with Bob Butler. I count myself fortunate to be among those. I thank all of you who have come to join us today. I want to point out in particular Bob's family. Cindy and Chris, two of his 4 daughters, are here, of his proud daughters, and we had an opportunity to share at lunch with many who knew Bob, many touching and heartwarming stories of Bob as a person. I know when I came to NIA, actually in the search process to identify a leader of NIA, I was judged by a very insightful search committee who found that I really didn't have the credentials for the job, which led me to become much more familiar with people like Bob Butler, and it's through contacts with him and others that I came to know and be a bit better known to the Institute, and have had the great privilege of living in Bob's very substantial shadow through this time. Among the areas of research which Bob knew to be important in the demographics of an aging population was the preservation of cognitive function, the threat that dementia and Alzheimer's disease provided, challenge to it. And so you're going to hear in a moment, in the introduction to our speaker for today, Ron Peterson, the very appropriate inaugural lecture in Bob Butler's honor. And so let me stop at this point to introduce the NIH director, Francis Collins, who in turn will introduce our speaker for today. Thank you for being here.
Thank you, Richard. Good afternoon to all of you. Yeah, it is a great privilege to be here, to have a chance to introduce the speaker for the inaugural Butler Lecture. I, too, briefly met with Dr. Butler, and obviously someone who's left an enormous imprint upon this noble institution called NIH. And it is fitting, indeed, to have the inaugural lecture delivered by somebody with such remarkable national and international stature, Dr. Ronald Peterson. And to have the topic also reflect an area of great national urgency, namely Alzheimer's disease. Currently, Alzheimer's disease is estimated to affect approximately 5 million Americans. And when you count up the economic cost, as was recently reported in an article in the New England Journal of Medicine, including that of caregivers who give of themselves over many hours, and no doubt hours associated with a great deal of distress at what's happening to their loved one, we add up quickly to approximately $200 billion a year that is costing our nation because of this disease. And it will only get worse in the coming years as our society ages, unless we come up with strategies to intervene, to identify means of prevention and treatment. And in that regard, we could hardly have a better speaker to lead us through some of the things that are going on right now in Alzheimer's disease. I will tell you this is a personal priority for the President of the United States. It is a priority for the NIH Director this year, despite the very difficult circumstances that we face with the sequester. It was possible by a great deal of struggle to identify an additional $40 million to put into Alzheimer's disease research because of some exceptional opportunities that have emerged in the last few months. In the President's budget for FY14, an additional $100 million was put forward for Alzheimer's, 80 of that to come to NIH to support research. The opportunities have never been more exciting, and yet the challenge is enormous. Well, Ron Peterson comes to this with a distinguished educational record and now as a distinguished leader in this field to help us think through where we might need to go. He got his PhD from the University of Minnesota, his MD from the Mayo Medical School. He did internship at Stanford, residency in neurology at Mayo, and a fellowship in behavioral neurology at the Beth Israel Hospital. He's currently professor of neurology and the Cora Canal professor of Alzheimer's disease research at the Mayo Clinic College of Medicine, and he is the director of the Mayo Alzheimer's Disease Research Center. And in addition to that, he really serves a remarkable role as chair of the HHS Secretary's Advisory Council on Alzheimer's Research, Care, and Services, reporting to Secretary Sebelius. This is a council established under the National Alzheimer's Project Act, which is a major development in terms of trying to coordinate our government's effort in research, care, and services. He is himself also a leading researcher in the field, having contributed and defined the disorder called mild cognitive impairment, and moving us closer and closer, as no doubt he will talk about, towards pre-symptomatic detection of Alzheimer's at the time where we probably have the best opportunity to intervene successfully. He runs a Mayo study of aging that follows some 3,000 volunteers, and I'm sure we'll be hearing a little bit about that, and has been a lead in suggesting that there might be a new paradigm for understanding this disease and leading to more successful early intervention. So I can't imagine a better person to ask to come to give this Butler lecture, and we are delighted that he accepted and he's here with us today. Please join me in welcoming Dr. Ronald Peterson.
Dr. Collins, Dr. Hodes, thank you very much for those kind words and the kind introduction, and to the family as well, Chris, Cindy, Richard, and James, for the opportunity. I'm truly humbled to do this after just visiting with the family and all at the luncheon. It was, I didn't know Dr. Butler personally. I knew of his accomplishments, but I think at this luncheon with all the testimonials that were given about him, it truly gave me a feel for the man himself, and makes me even more on the spot today to say something that's significant and worthwhile. But I understand from my colleague Zaven Kachurian that Dr. Butler was absolutely instrumental in establishing the Alzheimer's program at the National Institute on Aging. And that's what I'd like to talk about today a little bit in terms of what NIH and NIA in particular have contributed to the field in moving it forward with how we define the disease today and how we measure its progression, hopefully leading toward interventions that are going to have a true effect. These are my disclosures. I don't think they're all that relevant, but nevertheless, I should present those. So, new criteria for Alzheimer's disease. Gee, don't we know what we're talking about? We've been doing this disease for several decades now, and in fact, the criteria that were established in 1984 were really pretty good and stood the test of time for over 25 years. At the same time, a great deal of information accumulated over that time about the basic biology of the disease, clinically, pathophysiologically, as well as what's not Alzheimer's disease. So we acquired a lot of information about frontotemporal dementia, dementia with Lewy bodies, vascular dementia, so we can kind of refine our criteria to a greater extent. And this led to the work groups being formulated. Tony Phelps, Nina Silverberg were instrumental in putting these together at NIA with the Alzheimer's Association to really say, what do we know about Alzheimer's disease now and how can we refine these criteria? This led to several publications in Alzheimer's and Dementia in 2011 that really outlined what we were going to do. And my colleague, Dr. Cliff Jack at Mayo, was one of the, I think, the thought leaders. A lot of people contributed, but he was a real thought leader in this whole process because he was the one who published in Lancet Neurology in 2010 this model. It's just a model, it's a hypothetical model, and here we're looking at biomarkers normal to abnormal on the y-axis and clinical progression on the x-axis. And what the model posits is that the initiating or an initiating process early in the Alzheimer's progression is the laying down of this protein, the amyloid beta A beta protein. But note that most of the action of the protein occurs early in the disease when people are essentially asymptomatic. The process starts early. The analogy we often use is heart disease. The atherosclerotic plaque or the initial features of it are laid down years before people get angina, years before people have heart failure or a myocardial infarction. Downstream from the amyloid then is the deposition of tau. Tau mismetabolized, another protein downstream. Plaques and tangles are the disease. Tau's the tangled protein, amyloid being the plaque protein. But this happens subsequently. Only then are we able to measure some of the changes with, say, brain structure. So on scanning, we can now pick up atrophy in various regions of the brain. This is the biology that's happening. But we as clinicians now start to say, oh, gee, they're getting a little forgetful down here. But all this has happened a priori, and then we make the diagnosis of dementia when functional abilities become impaired. So memory, functional abilities down here, but look at what's happening back upstream. So this was a heuristic model that was published in 2010, but has been the absolute catalyst for a huge amount of research trying to investigate, is this accurate or not? Part of the thinking on this comes from a study done in Australia by Chris Rowe and colleagues in the Australian ADNI type study of aging, indicating that you can now measure with amyloid imaging, you can measure plaques in the brain very early on when people are asymptomatic, yet the disease doesn't present itself clinically for many years down the road. So there is, in fact, a 15-year window between the onset of the biologic process and the clinical symptomatology. That's good news, bad news. It gives us a time for intervening, but it also means a lot of damage is being done, so to speak, in the brain by not getting in earlier rather than later. So with this as a backdrop then, the new criteria looked at two sets of biomarkers. Early biomarkers, those that reflect amyloid deposition, and later biomarkers that reflect neurodegeneration picked up by structural MR, FDG PET for metabolism, and CSF tau measures. So what are we talking about? So we can talk about, from a neuroimaging perspective, structural MR. We can talk about functional MR, as functional PET, looking at metabolism in the brain, and then we can look at molecular imaging to see what is in fact underlying some of those processes. So what do we mean by structural imaging? So here are some coronal cuts of an MRI scan. Normal, MCI, AD. Note the medial temporal lobe structures here are relatively preserved in the normal individual. The hippocampi are starting to shrink here in the MCI, and there's gross atrophy in the whole brain, but particularly in medial temporal lobe structures when you have the fully developed dementia stage of the disease. So here's a rendering then from our study that Dr. Collins indicated, the Mayo Clinic study of aging, of brains of individuals who are normal versus those who have the dementia of Alzheimer's disease. And the colors now refer to the areas of the greatest gray matter change. So here we're looking at the left hemisphere, here we're looking at the medial aspects of the hemisphere, and here we see, so the disease does not begin everywhere, it begins in very localized regions of the brain, and these lead to some of the symptoms we see in the disease. So this is structural imaging. Functional imaging, what about now if we talk about FDG PET? Fluorodeoxyglucose PET metabolism. Let's just look at the bottom panel here. Here's a sagittal cut looking at the right hemisphere, left hemisphere. To the extent we see the colors now, the greens, the yellows, the reds, the oranges, those are areas of decreased metabolism. The brain's not working so well. And this is the Alzheimer's signature. And we can get cute about it. We can put numbers on it so we can actually do quantitative estimates. This region of the brain is hypometabolic relative to that region of the brain. So we're pretty good at that. So let's look at a similar kind of rendering now, looking at hypometabolism indicated by the colors again. Colors indicating regions of the brain. Notice to the posterior cingulate here on the medial aspect of the brain, a little bit of frontal region, but by and large, we're talking about temporal lobe and parietal lobe hypometabolism in individuals developing Alzheimer's disease. And then the latest generation of imaging is molecular neuroimaging. So now we can actually look at the deposition of amyloid in the brain. So here are some axial cuts of a PET scan, cognitively normal, mild cognitive impairment, dementia due to Alzheimer's disease. We're looking here for the redness now. The redness implies that the tracer is being retained in the brain. So in dementia, we see it. In the cognitively normal person, nothing going on out here in the cortex, some nonspecific white matter uptake. In the MCI person, kind of in between. A little bit of the redness because, in fact, this person's on the road to dementia. But note, this is Pittsburgh compound B, a C11 compound designed to pick up amyloid deposition in the idealized form. You go to the community, and I'll talk a bit later about the Mayo Clinic study of aging, which is a random sample of people in the community. What do you find? All combinations. So here, cognitively normal person, negative scan. Cognitively normal person, positive scan. MCI, memory impairment, negative scan, positive scan. So the million-dollar question is this person going to be symptomatic down here later on? Is this person going to develop dementia due to Alzheimer's disease? Probably, but in reality we don't know that because we know that many people live into their 80s, cognitively normal, die, have an autopsy, and have a head full of plaques and tangles in the brain. So did that develop yesterday? Did that develop 10 years ago, 20 years ago? We don't know. This technology now will give us that longitudinal ability to assess the temporal aspects of the buildup of this pathology. And so let's look then at a amyloid imaging scan, same rendering. So again, a lot of it back here in the posterior cuneus, here we are back here, and a little bit on the medial temporal lobe and in the frontal region. So this is where amyloid deposits. Again, so this is from the Mayo Clinic study of aging, looking at normals versus individuals with Alzheimer's disease. So based on that background then, the criteria were generated with clinical features, memory impairment, other cognitive domains impaired, adding the biomarkers. The two classes, molecular, neuropathology regarding amyloid deposition, and measures of neuronal injury. The other thing the criteria did was to expand what's called now the Alzheimer's disease spectrum. So heretofore, this is what we've been talking about, the dementia due to Alzheimer's disease. The 1984 criteria were down here. What we've learned is that there are earlier symptomatic presentations of the disease back at the mild cognitive impairment stage, and then even more aggressively, asymptomatic people might be identified as being at risk if they have the following features. So the spectrum now was included. And the first paper then that was published in those 4 papers, the first one was the introduction, the second one was dementia due to Alzheimer's disease. And I've got a couple of graphs that, tables that look like this. This is the label of the category. This column depicts the likelihood that this syndrome is due to underlying Alzheimer's disease pathology. What's the evidence on the A-beta side? What's the evidence on the neuronal injury side? So dementia due to AD then, probable dementia means that we've got the clinical syndrome of Alzheimer's dementia, but no other information, or the information's conflicting, it doesn't help us. So this is the clinical diagnosis. Now, can we do better? Yes, we can do better if we have the clinical syndrome and some positive biomarkers. So neuronal injury, positive here. That makes us think we're on the road to Alzheimer's disease. We can do even better if we have evidence of neuronal injury and amyloid deposition with the clinical presentation, gives us the highest likelihood that this is Alzheimer's disease. Give and take, you cut the brain, it's Alzheimer's disease. But it's particularly helpful when we have atypical clinical presentations. So what if it's not memory? What if it's language? What if it's attention executive function or posterior cortical atrophy, so-called visuospatial presentation? Might be Alzheimer's disease, so you've got an unusual presentation. You do the biomarkers, they're both positive, still, high probability, this is Alzheimer's disease. And then if we do the biomarkers and they're negative, that tells us unlikely to be due to Alzheimer's disease. We better look elsewhere because there's something else going on, but it's not plaques and tangles. So this is the general strategy then by which the criteria were generated. Okay, so this was dementia due to Alzheimer's. What about mild cognitive impairment? What is this? Well, mild cognitive impairment, we wrote a paper a couple of years ago for clinicians sort of characterizing what is this, and it really refers to the fact that people are generally a little memory impaired, other cognitive domains relatively preserved, functional abilities intact, but their memory is not normal. So they're sort of in between land. And over 10 years ago now, the American Academy of Neurology did an evidence-based medicine review of the literature and said, yeah, this is an important topic, let's pay attention to it. But what the American Academy of Neurology is doing now is, let's look at it again. Here are the number of publications on MCI in the 1990s, virtually none. But what's happened since has been an explosion in this literature. So the American Academy of Neurology is now undertaking another evidence-based medicine exercise to tell us, is this a useful clinical entity? What can we do about it? How do we measure it? And how do we predict progression? So this is kind of this in-between category. And this led to the third paper in that set of four, which is the diagnosis of mild cognitive impairment due to Alzheimer's disease. So this now gets at how can we define that intermediate category. Using the same scheme then, we talk about MCI without any other information. So but just based on the clinical criteria, is this in fact MCI? I think so. Is it Alzheimer's disease? Maybe yes, maybe no. Can we help ourselves? We can with biomarkers. So now if we get evidence for A beta deposition, either by CSF or PET scanning, we're now thinking, this is a little more likely due to Alzheimer's disease. What about the other way around? We've got MR atrophy or hypometabolism on the FDG PET scan. That might be also evidence for intermediate. Of course, if we have both, then even though this is a very mild clinical syndrome, it's likely that the underlying pathology is Alzheimer's disease. Everything's lining up. And of course, we have the negative instances. You have the syndrome, you do the biomarkers, they're negative, better look elsewhere. Could be depression, could be medication side effect, could be a bunch of other things that are causing the memory impairment, but it's probably not Alzheimer's disease. And then finally, I think the most out front, avant-garde, aggressive aspect of the criteria ventured into the preclinical space. So these are individuals now who are clinically normal. And this paper outlined people, again, who are clinically normal but might be at risk. So how do we do this? The preclinical stage was broken into, the preclinical phase was broken into three stages. Stage one, clinically normal, but you have evidence of amyloid deposition. Stage two, you have amyloid deposition plus neurodegeneration, but you're clinically normal. Stage three, you got both of these and a little clinical wiggle. You're still normal, but you're not quite as good as you used to be. So something's going on. You're a little bit concerned that there's something going on with this individual. Of course, there's got to be a stage zero. What's that called? Aging. That's normal aging. Okay? I mean, there's a whole bunch of people there, I think, I hope, that are not on the Alzheimer's disease pathway. So these are four stages then that need to be evaluated. So looking at that model that Dr. Jack put up a couple of years ago, this would be stage zero in the preclinical. Everything's negative. This is stage one. You've just got amyloid deposition. Stage two, you've got amyloid deposition plus neurodegeneration, and then you got a little bit of a clinical signal. So this maps fairly well onto the model. Now, $1 million question, do the criteria work? I'm going to address this in 3 different ways. One is with an individual case, an actual clinical case. How do you use this if you're a clinician out there? And then secondly, look at one of the large clinical simulated trials, and then look at a population-based example. So let's look at a case. This is a real person I had seen a few years ago, 53-year-old woman, year-and-a-half history of loss of self-confidence. Her husband was being asked to move to another university to chair a department. She didn't want to go. She felt she was uncomfortable, didn't have confidence in making the transition. She's saying, gee, I just can't think very well. She's forgetting conversations. Her daughters, adult children, saying, Mom's just not the same. She's having problems with reading, retaining what she's reading. She used to be the family compass in the car. Now, not so much. Sleeping well, concerned but not depressed. Very important. Family history, negative for dementia. 53-year-old, the first question you ask is, how does the family look? Because you're thinking about a familial form. So a 53-year-old with this kind of a history, and you say, gee, I'm uncomfortable calling this Alzheimer's disease in this particular person. Rest of her history is there, not too dramatic. So we evaluate her. We do some cognitive testing. This thing, short testamental status, like a mini mental, 37 out of 38, not too bad. Her IQ kind of average-ish. And on functions of domain of attention, executive function, she's hanging around the middle where you would expect from her IQ. Language, she's actually quite good with language, 90th percentile. Visual spatial skills, hanging around the middle, so kind of where you'd expect. But in fact, her memory function is not what you'd expect. She's forgetting more information than she ought to. She just isn't as crisp as she used to be or as crisp as she ought to be. So based on this cognitive profile with that history, we called her amnestic mild cognitive impairment. So where is she on this scheme? She's up here. She has the clinical syndrome, but we don't have any biomarker data to dissuade us or encourage us, whatever's going on. So we do an MR scan. We do the MR, here's what it looks like. She's got a little bit of atrophy, but in Cliff Jack's hands, it's within normal for her age. Not squeaky clean normal, but it's close enough. So her MR looks okay. So we do an FDG PET scan. And here she has a lot of hypometabolism here in her parietal and temporal region in the right hemisphere, a little bit on the left. And in fact, Val Lowe is the nuclear medicine specialist with us, and he says this is abnormal for our population. 1.3 being the cutoff, she's 1.14. So she does have some evidence for neurodegeneration. What about amyloid? Here's the rest of her PET scan. Here's her amyloid scan. So now we do a Pittsburgh compound B scan on her. The ratio, the abnormal ratio in most centers, our center is 1.5. Anything above 1.5 is abnormal. She has evidence of amyloid in her brain at age 53 with a memory impairment. So where is she now in the criteria? MCI, due to Alzheimer's disease, high likelihood. Evidence for amyloid deposition, evidence for hypometabolism on PET. So I'm reluctant as a clinician to label her as having that, but the biomarkers here have really tipped me in that direction. We continue to follow her every year. 2 years later, now she's progressed clinically. Getting lost, she's on medication, but she's on getting lost, frequent forgetting, not driving, more despondent, needing assistance. Her cognitive profile, I won't go through the details, but it has declined in virtually every domain. So she's poorer now, functioning-wise, than she was 2 years earlier. Now her MR does in fact show atrophy of the medial temporal lobe. So now she has abnormal structural imaging. Her FDG PET is exaggerated what we saw 2 years earlier, abnormal again, and we see it both in the right hemisphere here, and we see it in the left hemisphere as well. And her amyloid imaging scan was 2.5, now it's 2.7. So she's even acquired more amyloid during that interval. And unfortunately now she's progressed to dementia due to Alzheimer's disease, high likelihood. And so here's a case, unfortunately, of a very young woman who, in fact, is developing, for all intents and purposes, Alzheimer's disease. So this is why the biomarkers are helpful in this kind of a setting. What we lack, of course, is now, why didn't you jump in and give her that magic immunotherapy or whatever it would be when she was 53? We'd like to, if in fact the therapies were out there. They're under development. So that's an individual case. Now, what about in larger series? So the Alzheimer's Disease Neuroimaging Initiative and the Mayo Clinic Study of Aging. This is a international study that really is looking at the role of biomarkers in normal MCI and dementia due to Alzheimer's disease. How are they performing? But this is meant to be a simulated clinical trials population. And you know that people who come into clinical trials, very important, but they're not the average guy on the street. So we're hoping that the Mayo Clinic Study of Aging, which is a population-based study, complements that. So again, the Alzheimer's Disease Neuroimaging Initiative, supported by the National Institute on Aging and the FNIH, is a very, very successful program involving multiple sites around the US and Canada, enrolling hundreds and hundreds of subjects, doing state-of-the-art technology, imaging, a variety of MR scans here, DTI, ASL, a whole host of imaging parameters looking at these individuals, as well as obtaining spinal fluid on these people. Here's an example of what the data looked like at one of our recent progress report meetings. So this is amyloid imaging. Here's the cutoff. To the left is negative amyloid imaging. To the right is positive. Normal subjects, mostly negative, but a few positives out here. Early and late stages of MCI kind of go in progression, as you would see, and you get to the dementia stage of Alzheimer's disease, and most of the people are positive. So the data that are coming in are very consistent with what the theoretical model would predict. Does it make any difference? Well, here's healthy control subjects, and if in fact, if you are amyloid positive, your odds ratio is 4 to 5 that you're going to progress on to MCI or greater degrees of impairment. If you already have some cognitive impairment at the MCI stage and you're amyloid positive, the odds ratio goes up to 7. So these are data that we're thinking are contributing to the model that in fact we can use biomarkers to predict what's going to happen down the road. That's a clinical trials population. Valuable study, very important. But does it reflect what's happening out in the community? We have several of these meetings periodically with the FDA, and Rusty Katz, who's retiring from the FDA and Central Nervous System, oversees central nervous system drugs, always asks the questions when you show him data like this. He says, that's great, but what's happening in Peoria? Because he's responsible for how, in fact, these cutting-edge technologies perform out in the real world. So, is the real world Olmsted County, Minnesota? I hope not. I hope not. It snowed 14 inches there last Thursday. You don't want to go there if you don't have to. But anyway, the Mayo Clinic is set up in a very unique situation, being a big institution in a small town. Consequently, we provide basically all of the health care for the people who live around us. So we began a population-based study sponsored by NIA in 2004, where we're randomly sampling non-demented individuals. So people, we know who's in our community already has the diagnosis of dementia or Alzheimer's disease. We remove them from the population, and we're left with people who are not demented, normal MCI. And in fact have began this in 2004 with individuals aged 70 to 89, because that's where the action was. But we soon realized that in fact the disease process is starting 15 to 20 years earlier. So we put in a competing supplement. Dallas Anderson is our program officer, put in a competing supplement now to extend the study down to age 50. So now we're capturing people over 4 decades, 50 to 90, again, randomly sampled from the population. And here's what the study looks like. I won't go into details, but we see people back about every 15 months. We see them, we do a complete clinical, we image as many as possible. We're even doing spinal taps, et cetera. We're getting people, and we're trying to keep 2,000 people active in the 70 to 90 and 50 to 70 cohorts. So we replenish every few years because of mostly death, not attrition, but people die at this age. So we try to keep 2,000 people active. We replenish using the same random sampling procedure. So this is that scheme compressed up here for the 70-year-olds. For the 50-year-olds, we've just begun now, and we're starting to recruit those individuals and are beginning to see them back for their first reevaluation. So again, covering 4 decades of individuals who are sampled from the general community. Won't go into details, but everybody gets a thorough evaluation. So we don't do any staging, screening kind of thing. If you fail this test, then you get the full deal. We give the full deal to everybody. So everybody gets a thorough history of their medical examination, of their medical history, using the medical records that we have available on all of these individuals, often back to birth, because people live, it tends to be a fairly stable community. We do a neurologic examination. Physician does a mental status exam, neurologic exam, and we do a rather extensive neuropsychological evaluation. Then everybody gets together and argues about whether this person is normal or not normal or whatever. We're also gathering a lot of information and data, biospecimens that may be important today, may be important tomorrow. So we're in the original 2,000 people, here's how they looked. We did MR scans at about 2/3 of them. We got DNA and blood on everybody. It's all aliquoted, frozen away. We have over 500,000 samples in our laboratory, frozen away at Mayo for now and for future purposes. Then in the extension of the study, we've added 1,000 new subjects in the older cohort. We're starting in the younger cohort. We're doing the annual follow-ups, and here's the important, we're starting to get more biomarkers. So we're getting CSFs, we're getting MRIs, we're getting PET scans, FDG PET, and amyloid imaging PETs on these individuals. So, how do the criteria fare when you look at this kind of a population? The MCI then, you'll find that when you take the biomarkers and you break them out, they fall into one of 4 categories. Biomarker negative. These people all have mild cognitive impairment now, so they're memory impaired. But some are biomarker negative. Some have amyloid only, neurodegeneration negative. Some have amyloid plus neurodegeneration. And then an interesting group came up that we hadn't anticipated, people who were amyloid negative, but neurodegeneration positive. So they have evidence of atrophy or hypometabolism, in spite of the fact that they don't have amyloid present. So who are these? But by studying the whole population, you capture these people that the model may not have included a priori. So here's what it looks like, and this is cutting edge data. This paper was just accepted in the Annals of Neurology last week, that we have about 12% of the people with MCI now who are biomarker negative, another 12 to 14% who are amyloid only. We've got, 43 or so percent amyloid plus neurodegeneration, but we have a big chunk of people who are degeneration positive without amyloid. So who are they and what's going to happen to them? So, very preliminary data. I even hesitate to put this up because the numbers are are based on relatively small numbers. But what about that group now that is MCI but biomarker negative? What happens to them? Very few go on to over 1 year. We're only looking at 1 year, okay, limitation. Only 8% go on. Half of them are normal next time, meaning they bounce around a little bit in their clinical evaluation, and about half of them kind of stay MCI-ish, but again, biomarker negative. What about the group who's MCI, amyloid only positive? Again, not much happens over the course of only 1 year in those folks. A bunch of them bounce backwards. They're very, very mild. And about 64 or so percent kind of hang out in the same category, to be determined down the road. Now, what about the people who have the syndrome, evidence for amyloid plus neurodegeneration? Over 1 year, now we're seeing some action. So people are starting to progress now to the dementia syndrome. So we're adding things up. Very relatively small number of these individuals regress, so to speak, and a bunch of them stay where they are. So you get these two together, you've got about 95% of the people are going to remain 1 year memory impaired or progress on. So something's happening in this group. But the interesting group, again, is the people who have the diagnosis of MCI, the clinical syndrome, no amyloid, but do have evidence of neurodegeneration. They also are going on to some form of dementia, and some of them bounce back, and a bunch of them, half of them stay where they are. So this is a very interesting group from an aging perspective, and I think Dr. Butler would have been interested in this group because they don't fit the Alzheimer's model, yet they're out there in the general community, they're real, they may have something that's treatable, they may have some intervention that we can, because of vascular diseases, of tauopathy, Parkinson's, a whole host of things could be going on. So that's MCI. Let's turn now to the preclinical, the normal people in the general community. And here's the scheme again that we use, stage 1, 2, 3. So we're looking now at doing these on people in the general community. What we find is that stage 1, amyloid only, about 16% of the normal people. Now we're talking age range 70 to 90 in this study. Another 12% have amyloid plus some evidence of neurodegeneration. A smaller proportion has the amyloid degeneration plus a little bit of a cognitive signal. But again, we have 23% of the group in the general population has evidence of neurodegeneration without amyloid. Something else is going on in these people as well. And then, of course, we've got the big chunk of 43%, thank goodness, who are really kind of normal. These people are tooling along, they're cognitively normal, and they don't have any biomarker abnormalities. So half the population, basically. And here's what these folks look like schematically. So biomarker negative is what you would expect in a normal population, but this is interesting here, and in particular this group of what we have labeled as SNAP, suspected non-amyloid pathology, non-Alzheimer's pathology, because they have something, but it's not Alzheimer's disease. So using the same depiction, the same scheme again, where do the numbers shake out? 43% are stage 0, normal. 16% have evidence of just amyloid. 12% amyloid plus neuronal injury. And another 3% have that plus cognitive. So about 30% of the population, normal aging, is amyloid positive. This is why we need to follow these people. Is this somewhere where we want to intervene? Probably, but are all these people going to go on to symptomatic Alzheimer's disease? I don't know. We'll see. Again, why we need to look at the population. So what happens to those groups longitudinally? Only 12 months of follow-up. Stage 0, don't go anywhere, but stage 1, 2, and 3, increasing likelihood that they're going to progress on to MCI or dementia. And then this neurodegeneration group is kind of in between as to what's going to happen to them. So tantalizing data that we're really tapping in on something, but the precise meaning of it needs to be realized with more longitudinal follow-up. And I think, is there something here that we can intervene? Is there something we can do about these folks to get in sooner than later? Now, these are a couple slides I just picked up last week. I was at the Gladstone, San Francisco, and some people presented some data showing the next imaging horizon might very well be our ability to image tau, that is, the other protein. We can do it with CSF right now. We can pick up an index of tau. Here are some images of an F18 tau agent that's under development. I got these slides from Mark Minton. And here again, we're starting to see that there may be tau deposition in addition. Well, we don't know what the amyloid looks like, probably positive, but isn't that an interesting question to ask how the amyloid scans compare to the tau scans? And here's another look at it of somebody who's normal, healthy, mild MCI, mild dementia of Alzheimer's disease, severe dementia. These are sagittal cuts now, and we're starting to see the tau pathology come here into the temporal region, the parietal region, not unlike we saw with FDG PET. So very early, very new. We want to incorporate this into our community study as well to give us a more complete picture of the amyloid and tau story in evolving aging. So let me wrap up by saying, do they work? Do the criteria work? That was the question we asked at the outset. Yeah, well, sort of. Yeah, I think they do in general. I think most things are falling into line with the theory, with the thinking that, in fact, there is this cascade of events. But there are a lot of questions that need to be answered. I've thrown up things as if they're decidedly normal or abnormal. That's a big deal. Some people may say, well, I don't like your threshold. If you change your threshold a little bit, you change the whole landscape of the number of people. So absolutely, this is something that needs to be evaluated. Is the temporal ordering right? Does amyloid always occur first? Some evidence, and Cliff Jack has revised the model in a Lancet Neurology paper this year, saying not always. There could be instances where, in fact, tau and tangles get deposited even before amyloid in some individuals, and there may be a synergistic interaction between the amyloid and the tau. So it's a good model, but not definitive right now. What happens if we do the markers for Alzheimer's disease, one goes north and one goes south? What does that mean? I don't know. I think we need to find out. Again, studying a community will help us delineate that. Imaging versus CSF. Now we're getting down to practicality. Imaging is great, gives us a lot of good pictures, distributions, anatomical distributions, but it's expensive. It costs thousands of dollars to do all these scans. CSF, spinal tap, well, spinal tap's not the easiest thing in the world, but it's clearly cheaper. If you get the same kind of information, which way are we going to go with that? Needs to be determined. The cost. We need more data, no question about it. And I think, though, as Rusty Katz was saying, we really need to see how these markers perform in the general population, because that's where they're going to be applied. So if you approve something, you approve a drug for Alzheimer's disease based on somebody having a positive amyloid imaging scan, positive CSF marker for amyloid, you better be certain that, in fact, those are reliable estimates. So we really need to know how these perform out in the general population. And then, Tony loves this, but DSM-5 will be released next week in San Francisco at the American Psychiatric Association meeting. DSM-5, as you know, is the sort of the Bible for psychiatrists. It determines, and it's going to feed into the categorization of the coding diagnoses for most diagnostic disorders, in fact, feeds from the DSM. So DSM-5 will, in fact, influence what's going to happen in the field. And the important aspect to note is that the Alzheimer's criteria that were developed 2 years ago influenced this depiction, insofar as MCI and mild neurocognitive disorder had really not been considered prior to the development of criteria for Alzheimer's disease. So this is going to now influence what's going on in the broader community of cognitive disorders. So here's where we are. Here's where we have been making the diagnosis of Alzheimer's disease for the last several decades. I think where we're moving now is to an appreciation that a milder set of symptoms will, in fact, constitute the earliest features of Alzheimer's disease. And if we augment that now with certain biomarkers and other features, we can enhance the likelihood that we are dealing with an underlying Alzheimer's disorder. Of course, we don't want to end there. We want to go back to when people are normal and, in fact, see if what we've learned regarding these biomarkers in the symptomatic stage apply back here, so that we can apply our therapies earlier and more effectively before damage is done in the central nervous system. So let me stop here and thank my colleagues at the 3 Mayo Clinic sites in Minnesota, Florida, and Arizona, because they contributed to a lot of the data that I've misrepresented today, and these are the people who did all the work. Let me just end by saying that, you know, as you look back, is this all just an academic exercise? Is this something that we do to really bide our time and try to apply for grant funding and the like, or does this have a real implication going forward? So I look back and try to uncover what might be the first recorded senior moment, maybe with consequences. And I found this. A couple of dinosaurs in a downpour sitting on a rock. They missed the boat. Is this why this species may have gone into extinction? I don't know, but it could be a little forgetfulness here. But let me thank you very much. I want to thank again the Butler family for the honor.
Thank you, Ron. We have time for some questions. The microphones in the aisle are there so that people listening over the web can hear the questions, and let's get right underway. Yes?
Yeah, you noted that sometimes people go from MCI to normal. Does it matter if the same clinician does the test?
Hopefully not, but in reality, yes. I mean, we have a paper now that's under review looking at people who have gone to the MCI diagnosis, bounced back to normal, bounce back to MCI, and if you follow those people out 8 to 10 years, even getting the MCI diagnosis on one occasion is not a good sign because ultimately those people reconvert. But your question is the consistency of the criteria application important? Absolutely.
Going forward, will all patients in the ADNI and Mayo studies get tau imaging? Will all go to autopsy? And finally, could you remind us about what the gold standard for diagnosis for Alzheimer's disease is?
Well, still the gold standard is the autopsy, plaques and tangles, amyloid, and tau at the time of autopsy. Will tau imaging be introduced? We hope so, maybe not today, tomorrow. We're trying to put it into our study in the community as soon as possible. I know the ADNI folks are trying to incorporate it too, but we have to get the technology worked out there. Autopsies, both studies try to achieve the highest autopsy rate in both studies. So ADNI has a neuropathology core that is designed to try to obtain as many autopsies as possible. In our community study, we do the same thing and get them to validate the ultimate biomarkers.
When you compare the PIB imaging to that of tau, it gave the appearance that the PIB was marking a high signal up in frontal cortex, while tau was more restricted to the temporal lobes. I was wondering if that is indeed the case. Have you looked at your different tests for working or executive function versus long-term memory and see if the scanning appears to segregate more in that way?
Good question. Thank you. I mean, I think in general the pattern of distribution of amyloid imaging does not always correlate with the underlying cognitive functions or clinical state of the patient. It's almost like if there's amyloid there may be some downstream effects, but it doesn't correlate as closely as you see. Even in very dramatic cases of like aphasic dementia, where you know most of the symptoms are coming from the left hemisphere, and you've got an amyloid deposition accounting for that clinical, the amyloid's everywhere. So, however, I would predict, and I don't know this, it's very early, that would not be the case with tau imaging. I think tau imaging would have a much closer imaging clinical correlation than you would see with amyloid.
Okay. Two questions. One, can you comment on the interplay between ApoE4 status and the neuroimaging data? And second question is a speculative one, and that is whether or not tau-related neuronal damage might be a different different disease than classical amyloid, but with the same clinical expression.
Very good question. So ApoE correlates very highly with amyloid deposition, as you would expect. I mean, it's not perfect, but it's very, very high, such that it's clearly related, ApoE is clearly related to the amyloid deposition. And the tau imaging, sorry, second question?
Primary tau abnormalities, which precede amyloid.
Yes, okay. Could there be different disease process? So tau imaging, in the model I alluded to that was published in 2013 in Lancet Neurology, does pose that there might be other processes where tau is deposited in the brain, not amyloid related, maybe aging related, whatever that might be, but tau is in fact deposited. However, if amyloid is deposited as well, there's a synergistic process, so then the tau deposition actually accelerates in the process. But there may be independent processes, maybe a different disease process as well.
While you're asking about that, what about chronic traumatic encephalopathy, which seems to be perhaps more of a tauopathy than an amyloid?
Exactly. Most of the data that have come forth with regard to traumatic brain injury in whatever circumstance you're talking about tends to be a tauopathy, a tangle disorder, rather than an amyloid disorder. So it may predispose to cognitive impairment and dementia, but may not be Alzheimer's disease per se. It's more of a tauopathy.
Ron, I want to follow up your question whether the criteria works, the new criteria. The time lag between when the first time the criteria was established, 1984, and the new NIA, NIH Alzheimer's Association criteria was 27 years. In order to answer your question, shouldn't we launch a formal mechanism through NAPA or through NIH where there is a formal mechanism for validating the criteria so that we re-examine the criteria on a more frequent basis? We're getting now very large populations through ADNI, your own study. There are multiple longitudinal studies, so we have the mechanism to accelerate the process in a formal way where we continuously re-examine and readjust the criteria.
I think that's an excellent point, Zalvin, that in fact we do need to revisit these criteria. So whether it's done, it probably could and should be done under the auspices of NIA and maybe the Alzheimer's Association, maybe at the annual international meeting where you could convene groups, do sort of an evidence-based medicine review of the literature. Is there enough evidence now to actually revise the criteria and change what we're talking about? I think that's highly likely. Interestingly, the one slide on DSM-5, DSM-5, is this huge manual that's put out for psychiatric disorders. They call it, all the other ones have been Roman numeral 1, 2, 3, 4. This is Arabic numeral 5. And years into it, I asked, why is that? It's because there probably will be a DSM 5.1, 0.2, but not a DSM 6. And that's because the individual disorders may be updated periodically depending on the status of the field. So it's conceivable that the neurocognitive disorders that are being described now may be revised in, say, 2 to 3 to 5 years or sooner if the data warrant that the criteria now should incorporate biomarkers because the data, the literature supports that. So I think those kinds of exercises are built into hopefully both the NIA, Alzheimer's Association criteria, and DSM-5 and ICD 9, 10, 11. That's what DSM feeds into ICD 10 and 11. Stanley?
I really enjoyed that presentation. So do you think when and if a potential drug develops for the treatment of Alzheimer's disease, that you're going to use your biomarker criteria rather than the clear evidence of cognitive dysfunction to initiate the use of that drug? There is a recent article in New England Journal suggesting they're changing the paradigm, but it's going to be relatively hard to start treating somebody who does not have a clear medical problem.
Right. No, it's a good point. I think it'll depend upon what's the nature of the therapy and what's the putative target of the therapy. So if the therapy for Alzheimer's disease is amyloid-based or tau-based, I think that people will require some type of a biomarker, imaging or spinal fluid, whatever, that in fact that particular target is present in that individual before. So I think the new therapies, hopefully when they're developed, will be a combination of the clinical symptoms plus the biomarker authenticity that in fact that target is active in that particular person.
It's been suggested by some that inflammation in the brain is one of the earliest stages leading on to Alzheimer's. Are there any imaging procedures that can detect inflammation in the brain?
I just had that discussion an hour ago with Stanley Rappaport with regard to imaging inflammation. There are some imaging agents developed, but they're not very good right now. Inflammation is a complex process as well. So what stage, what particular subtype are you in fact imaging? So, but yes, the point is well taken, that if we in fact had an imaging agent that would look at inflammation of the brain, that may very well be also an appropriate target for therapies to be developed, but we have to develop the imaging as well.
Well, there is a reception next in the library, which you're all invited to if you want to continue the conversation informally with the speaker. But meanwhile, let us thank again for a wonderful lecture, Dr. Ron Peterson.
Thank you. Good. Thank you. Appreciate it.